sex hormones and the heart. Actually, I'm really excited about this. I was just talking with Dong and some of the team there, is that I actually increased my testosterone today by exercising and keeping my weight down. So we're going to look at um, sex hormones on the heart. Fire away, guys and ladies.
All right. So my name is Dong, and I'm here on behalf of the Women's Cardiovascular Health webinar. And before we get started, I just want to acknowledge Hania, Aman, and Carla, who contributed to this webinar, but unfortunately couldn't be here today. So we'll start off by taking a look at what hormones are, and then we'll take a look at the different types of reasons why you might take hormones. There's menopausal hormone replacement, so that's to manage menopause symptoms. People might take hormones to prevent pregnancies, so that's for birth control. Men might consider taking testosterone, and there is also implications for transgender individuals considering gender-affirming hormone therapy. And we'll just take a look at all of these hormones in the context of how they affect the heart. So before we take a deep dive into that, let's first take a look at what hormones are. So hormones are essentially the chemical messengers of the body. They help with essentially messaging between all of the organ systems. And we have so many organ systems that are located all over our body, and there needs to be something in between them to coordinate their functions. And these are the chemical messengers that we call hormones. These hormones are created by the endocrine system, which is composed of specialized glands in the body, as well as reproductive organs such as the ovaries and the testes. These hormones are released into our bloodstream to circulate around the body, and depending on the hormone and the organ affected, they regulate functions like metabolism, growth and development, as well as sexual function. And here are some major sex hormones. The majority of the female sex hormones, which are hormones that primarily regulate sex development and sexual function, but also have various other effects, are created by the ovaries. The major sex hormones for females are estrogen and progesterone, as you may know, and the major sex hormone for male is testosterone. And although we refer to these commonly as female or male sex hormones, they do exist in the other respective sex. So first, let's take a look at progesterone. Progesterone is the key hormone that regulates a woman's monthly menstrual cycle, so the period. In the second half of this cycle, levels rise and act to thicken the lining of the uterus, or the endometrium. And the endometrium is important for pregnancy, as a fertilized egg will attach to the lining for nourishment. So if a fertilized egg does not attach, progesterone levels drop and the endometrium sheds, and this results in menstruation. Another sex hormone that we'll take a look at is estrogen. And estrogen is another hormone that is made by the ovaries. It also regulates the menstrual cycle. And when levels of estrogen drop, this also contributes to the breakdown of the endometrium. The main role of estrogen is for sexual reproductive development. It's responsible for the development of secondary sexual characteristics. And so this is the development of the breasts, pubic and armpit hair, as well as different other characteristics. However, estrogen also has effects all over the body and affects the gastrointestinal tract, urinary tract, the heart, blood vessels, hair, mucous membranes, and the brain. So now that we've taken a look at kind of what hormones do, let's move on to why somebody might take hormones exogenously. So why they might take external hormones and what that means for the heart. So one of the primary reasons that somebody might take hormones is to manage menopausal symptoms. So in menopause, the body is not making the same amount of estrogen and progesterone as it was previously, and hormone replacement is used essentially to manage the symptoms that accompany menopause and to replace the hormones that the body is no longer making. And the symptoms that I'm talking about mostly consist of hot flashes, vaginal dryness, and potentially sleep disturbances as well. So there are two main types of hormone replacement therapy for menopause. There's estrogen only hormone replacement, and there's also estrogen and progesterone combined hormone replacement. And estrogen and progesterone combined hormone replacement actually reduces the risk of uterine cancer, and it's the progesterone component that reduces the risk of uterine cancer. And this is why estrogen only hormone replacement is only recommended for those who have undergone a hysterectomy. So they've undergone a complete removal of the uterus, and therefore the risk of uterine cancer is not present. Otherwise, however, estrogen progesterone is the way to go as it minimizes this risk. And a bit of a not so fun fact is that hormone replacement used to be incorrectly prescribed for the prevention of heart disease. But as we will later find out, this was not the right move because this was largely based on a lot of observational data that hormone replacement was allegedly preventing heart disease. However, one of the large trials that marked a turning point in this practice is called the Women's Health Initiative. And in this trial, 27,347 postmenopausal.
Before you go, early in my career, I prescribed hormone replacement therapy like other physicians in the hope of preventing heart disease. Because we know that estrogen does actually lower your LDL cholesterol. It boosts your HDL cholesterol. And there's different types of evidence. The evidence that we had initially was observational data. So women who took hormones after the menopause had less heart disease compared to women who didn't have heart disease. We also had surrogate markers that estrogen lowers the lousy cholesterol and boosts HDL cholesterol. We knew also it raised triglycerides, and we knew it also can cause blood clots. So we knew all about that, but on balance, we thought that taking or prescribing women estrogens and progesterone, as you mentioned, if the uterus was intact, was important in preventing heart disease. We were wrong until we did randomized trials. And you mentioned the Women's Health Initiative and the HERS trial were two big landmark trials. Well, tell us a little bit more.
Yes, so the Women's Health Initiative was one of the large trials that, as Dr. Curnew mentioned, marked a turning point in this practice. And essentially, all of these women were either given estrogen, they were given combined estrogen and progesterone, or they were given placebo. So that is, they were given pills with no hormone containing. And it was found that those on combined estrogen and progesterone therapy actually experienced an increased risk of coronary heart disease, as well as an increased risk of stroke and an increased risk of breast cancer. Those on estrogen-only hormone replacement didn't find any observed effects on coronary heart disease risk. However, there was an increased risk of stroke. And there was some later evidence that suggested maybe transdermal estrogen-only hormone replacement therapy did not increase the risk of blood clots or stroke the same way that oral estrogen did. But it's been generally believed by a lot of physicians like Dr. Curnew that hormone replacement is generally unsafe.
The trial before then, these are called randomized controlled trials, where good observation is good observation, but it's not the same quality as randomized trials. As Stuart did a nice little webinar way back when, over a year ago, about the different types of evidence. Observations are good, but randomization where the patient and the doctor and people analyzing the data are blinded to information, getting rid of all biases. So a computer will select therapy to find for sure. That's a proper randomized controlled trials. And we have two large randomized controlled trials that's showing that taking oral estrogen and progesterone predominantly in postmenopausal women well after the menopause increase the risk of heart attacks, increase the risk of strokes, increase the risk of breast cancer, increase the risk of blood clots. Despite lowering the LDL cholesterol. Also, it lowers LP little a estrogens too as well. So again, is that observation is good, but randomized controlled trials are far superior at telling us. And that's why people get confused sometimes, because you can have these large data sets in 100,000 individuals that people who choose their therapy. Because what turns out is that women who chose estrogens and progesterones were more health conscious and had a lot more healthier behaviors. They weighed less, they exercised more, their blood pressures were lower, their cholesterol were better. And the hormones contribute to increasing risk of heart disease. And this was really a changing point. That's why people have to understand is that science grows at a certain rate. And we have to look at the quality of information. Now, physicians and other healthcare providers are trained to analyze this information. What I'm fearful for most people today is people just Google something, and what turns on the top of Google is based on hits, based on people paying in part, and it's always based on the best science. So rely on experts to help you in this circumstance. Dawn, tell us more.
All right. So the next part has a little more contention to it, but it was found by later research, certain secondary analyses of the Women's Health Initiative, as well as certain smaller scale randomized control trials, that hormone replacement might actually be safe for women who have started menopause for less than 10 years, or women who are 50 to 59 years of age. And these studies showed that for these populations, no increase in risk of coronary heart disease was observed, and no absolute excess risk of stroke was observed. However, like Dr. Curnew mentioned, there was considerable risk showed by the initial Women's Health Initiative, and there are considerable risks associated with hormone therapy. And it's incredibly important that individuals discuss this with your healthcare provider, as risks also vary by individual, and weigh the potential risks of hormone replacement against the severity of the menopausal symptoms that you might be experiencing.
So this is actually very interesting information. So there's also another randomized controlled trial of about 1,000 women were giving a different form of estrogens. Initial estrogens that we used was called Premarin, and that was felt in different cocktails of estrogens, designer estrogens may be safer. That remains to be proven. So if you look at from a purist point of view, a trial is calculated to have one positive endpoint. And if the trial is negative, looking for benefits in a negative trial is fraught with uncertainty and unreliability. If a trial is positive, it may be a little bit better to see who benefits the most and who benefits the least. So overall, randomized controlled trials show that hormone replacement therapy does harm after the menopause. Maybe closer to time of menopause, it may be different, because estrogen is a vasodilator, and that improves the health of the endothelium in experimental data. We got that wrong the first time around. So I think it needs to be proven better. So the view right now is that the reason to take hormone replacement therapy is that you have bad menopausal symptoms that is not tolerable, and you're going to take it for the lowest dose for the shortest period of time. But I would argue that it increases your risk of a blood clot, breast cancer, heart disease, and stroke. I haven't bought into this earlier age that it's safer. It may be, but no one has done a proper trial in that area to fully analyze that. So that's basically not enough data to support that. But again, it's like, as Don put, it's a contentious issue, and people can look at the data and come up with their analysis. So it's always, like you say, discuss things with your healthcare provider. And the best thing to do is obviously lower your risk of heart disease, know your blood pressure, know your cholesterol, eat well, exercise, keep your weight down. What's your thoughts, Don? What would you did a lot of reading in this area, and I'm sure you saw the pros and cons of this. What do you take away from this?
There's certainly a lot to consider. I think you're right in that we need to take a look at the best available type of evidence. And from what I've read, I did think that the timing hypothesis seemed quite convincing, but I do also agree that we might need more larger randomized control trials to reaffirm this before this can be, I guess, 100% supported. But I do agree that there are a lot of different lifestyle changes that can be made besides just hormone therapy. And so in order to manage menopausal symptoms, we can first of all avoid triggers. So alcohol and smoking have been shown to induce hot flashes, and so avoiding these is a good first step in avoiding the potential side effects of menopause. Staying cool can really help with hot flashes. So dressing in layers, keeping room temperature cool, having a cold towel on hand for when hot flashes do occur. Sleep disturbances are often cited as a side effect of menopause. And so it's really important to sleep well, maintain a regular time to go to bed, and also regular time waking. And additionally, mental health and mental illness has been associated with the post-menopause experience. And this is because of fluctuating hormone levels can lead to increased rates of depression and anxiety. And so it's also really important to seek social support to improve mental health and well-being. Not only can you let your family know how to best support you during this time, but also you can speak to healthcare providers, different people who have undergone menopause in order to share experiences, get advice, and just generally help each other out during this time. It's also important to stay active. There is only a weak trend observed for exercise and its effects on hot flashes. However, we do know that exercise has a lot of beneficial effects on mental health and physical health in general. And considering that those are both heavily affected by menopause, it's always a good idea to maintain good physical health and stay active. And eating healthy is actually also a really good way of avoiding or managing menopausal symptoms. Specifically, avoiding spicy foods is a good way to avoid triggering hot flashes a lot of the time. And on the topic of eating, you may have heard of something called isoflavones. And these are a compound that are found in soy that are thought to exert effects that are like estrogen. And the idea is that these isoflavones might act like hormone replacement almost and be able to counter the menopausal symptoms that people experience. But let's take a look at what the research says in terms of isoflavone effectiveness at managing menopausal symptoms. And like a lot of nutrition research, this was kind of really difficult to draw conclusions from because studies really differed in the methods of measurement. Some studies used soy and some of them used isoflavone extracted in pill form. But most recent literature actually suggests some degree of reduced severity and frequency of hot flashes with isoflavone intake. And as Dr. Curnew mentioned in a previous webinar, there was a randomized controlled trial that was on a smaller scale, which involved 38 people. And they were randomized to take a plant-based diet as well as half a cup of soy a day. And it was observed that in this group of women, there was a reduced severity and frequency of hot flashes. So there is that interesting potential of isoflavones and soy in being able to reduce hot flashes and manage menopause symptoms.
So, well, there's estrogens are much better at relieving menopausal complaints. Soy products are safe during menopause, and the estrogen-like properties do not contribute to cancer or to risk of blood clots. Japan is historically a population that eats a lot of soy products, and menopausal complaints are much less common in Japan. And so what I would do is that the reason for plant-based eating is that they're rich in anti-inflammatory components by eating lots of plants. And having a half a cup of soy is a good food. It's a good healthy protein. It's a complete protein. It's good for the planet. Remember, for every pound of vegetable protein that you can either eat that or you can use that to feed chicken and fish, and it's basically a factor of 3. So every pound of plants, you need 3 pounds of plants to make a pound of chicken and fish, and about 6 to 7 for beef. So it's good for the environment, and so we're all looking at ways of making an impact on the environment, and one is how you eat. And it is said that if most of us went to a plant-based eating, we can have tremendous reductions of global emission and be helpful in that circumstance. And for women going through menopause, it can actually decrease the severity and the amount of flushing. It's not magic. The trial is a good quality randomized trial, but it's relatively small. So I'm quite impressed with that. So I don't have menopausal complaints. I think I cause menopausal causing flushing in a lot of people some days. And what I try to do is actually put I learned from Aditi about soaking my soya, putting into a pot, and I just throw them everywhere in a salad. And I think if someone's going through menopausal complaints, I would certainly give this a shot. And I think it's something to think about. So it's good for you, it's good for the animals, good for the planet, and you'll flush less. Thank you. What's your thoughts about soy in general, Dawn?
I personally have not experienced any menopausal symptoms, so I don't actually know what soy. I haven't seen the effects of soy in person, but it certainly seems promising. And if it works, it works.
Also has some calcium there too as well. So it's just a good healthy food. So soy is something that Didi taught me about diet. It's a complete protein. It's a health food. It's good for the planet, good for the animals, and for women going through menopause, it decreases severity of flushing.
Mm-hmm. So our next section is going to take a look at the use of hormones as contraceptives and their associated risks with the heart. So before we dive into the heart risks associated with hormonal contraceptives, let's take a look at what hormonal contraceptives do and how they act. So most oral forms of hormonal contraceptives consist of a synthetic estrogen and a progestin, and these are called a combination contraceptive. And they work together to prevent pregnancy through a number of ways, one of which is they inhibit ovulation by preventing the release of an egg. So the ovaries don't release an egg, and then no fertilization can occur, so no baby develops. It can also alter the endometrium. So the endometrium is the lining of the uterus, and by making the endometrium thin and inactive, it alters the environment such that a fetus can't grow there. And it can also act to thicken cervical mucus, so it makes it much more difficult for sperm to migrate into the uterus. There are also different types of birth control. So combination contraceptives, the ones that I just discussed, can be given through three main routes. They can be given orally, through a patch through the skin, or through the vaginal route. There can also be progestin-only hormone replacements. So progestin is the main hormone that is responsible for preventing pregnancy, but estrogen is added to these pills and combination contraceptives because estrogen can help maintain a regular bleeding cycle. Progestin-only hormone replacements may also be given orally. They can also be implanted beneath the skin, they can be injected in the muscle, or they can be intrauterine. So they can be placed inside the uterus. There is also intrauterine devices. So these are essentially devices that can be placed inside the uterus. They can be hormonal, so they can exert similar effects to the contraceptives through hormones, or they can be made out of copper. And the copper intrauterine devices essentially just disrupt the lining of the uterus, causes a state of inflammation, and then this would prevent sperm or egg from being able to develop in that environment. There are also condoms, which is just basically a physical barrier to prevent pregnancy. So I mentioned that combination contraceptives include estrogen to help maintain the regularity of bleeding. Unfortunately, estrogen is actually associated in these combination contraceptives with certain cardiovascular risks. So combination contraceptives may actually increase the risk of blood pressure. They can also increase the risk of clotting disorders. So estrogen increases this risk, and this might cause an increased risk of stroke, increased risk of clotting in the veins, increased risk of pulmonary embolisms. And it was found that especially in women who smoke and are over 35 years old, this risk is pronounced. And so for women who already have hypertension, so they already have high blood pressure, or they have a history of stroke, heart attack, deep vein thrombosis, or pulmonary embolisms, it's not recommended that they take combination contraceptives. But what does this mean for the individual? So while for these specific populations that I just mentioned, it's not ideal to take combination contraceptives, there are other methods that could be considered. There are non-hormonal birth control methods, such as the copper intrauterine device. There are condoms, as well as there's progestin-only birth control that I mentioned previously. And progestin-only birth control hasn't been associated with the same cardiovascular risks that the combination pills have been associated with, and they are well suited for women with hypertension and cardiovascular history. And we discussed all of these potential risk factors for combination therapy, but These combination contraceptives don't hold much risk for women who aren't from the specific populations that I mentioned before. But again, risk factors vary very much depending on individual, and it's important to discuss this with your healthcare provider and weigh the risks of pregnancy, unplanned pregnancy, against the risks that hormone and birth control can potentially mean. The risks of unplanned pregnancy can be pretty detrimental as well, both to the mother and to the fetus. In our next section, we take a look at the effects of testosterone on the heart. So before we get into that, let's take a look first at what testosterone does. So testosterone is a hormone that particularly aids men in maintaining bone density, muscle strength and mass, as well as sex drive. And testosterone levels within the body usually peak at around adolescence and in early adulthood. And in one's 30s and 40s, testosterone can actually decrease a little bit. So you might be wondering, why would somebody take testosterone therapy and what are the effects of that? Well, you may or may not have seen certain direct advertising to people who've been experiencing fatigue, especially middle-aged men, encouraging them to take testosterone. This is actually not recommended. Testosterone therapy is only indicated in people who have hypogonadism. And hypogonadism is a condition where there is the inability to produce normal amounts of testosterone due to issues regarding the testes or the pituitary gland. And so in these individuals, as we'll take a look at later, testosterone therapy is actually beneficial. However, you might be wondering, what about testosterone therapy for just older men in general? Well, the research is not really conclusive on this aspect as well. Some initial studies have indicated that testosterone therapy can increase the risk of heart attack in men aged 65 years or older, and that men who have a history of coronary heart disease and use testosterone therapy have a higher frequency of heart problems. However, this was followed by some other studies that show no increase in the risk of cardiovascular events, and some other further analyses that don't show any risk in men who receive testosterone therapy. So the general conclusion is that there needs to be a lot more research done to fully understand the impacts of testosterone therapy on the cardiovascular health of men. However, there is very much that possibility of increased cardiovascular risk, and therefore it should not be used in healthy middle-aged older men who have no hypogonadism.
Yeah, this is another interesting area. So what we know for sure is that in good quality data, that it's important for bone density, muscle mass, increases hemoglobin. Testosterone will increase the risk of prostate cancer. And it does affect lipid parameters in a favorable fashion, that we know. We have one randomized controlled trial in men over the age of 65 years of age, showing that men that got testosterone had a higher incidence of heart attacks. We have data from angiographic studies, which we call, which is observational match, showing that angiograms look worse if you're taking testosterone compared to males not taking testosterone. And we have lots of observational data that testosterone is safe in observational data. And so we got that in women. We had observational data that saying that hormone replacement therapy was protective as well, and until you got to observational data versus case control and people who choose their therapy. So the bottom line to all this is that we don't know. And so is that as Dawn points out, if you are testosterone deficient, that's a different story, which is quite rare. As we get older, testosterone levels fall. And what is a normal free testosterone should be, I think, is still somewhat unknown and controversial right now. So one way to actually boost your testosterone levels, as Dawn will tell you, is that losing weight, and also regular exercise has some impact. And narcotics can actually, if you're taking pain pills, that can actually, not Tylenol, but actually narcotics can actually lower your testosterone level as well. So to me, what I did today is I went to the gym, played an hour of tennis. I went for a 35-kilometer bike ride today. So I'm improving my quality of life. I'm helping my bone health through that mechanism. I had soy on my salad today with a bunch of soybeans. So that's the way I'm going to try to treat my um, my cardiovascular health and my hormonal health at this stage of the game. But I understand that for some people who are depressed, sad, sexual dysfunction, taking testosterone might have some advantages. But um, I'm fearful we don't know enough right now, and so I'm conserved by nature. And by nature is that I'm a little bit afraid of providing testosterone. It will increase um, your risk of prostate cancer. It will increase your hemoglobin, and some people it's an excessive rise. So if you're on testosterone, you need to be followed, and you'll see all sorts of camps about this. And some people feel very, very strongly about testosterone. I'm not so sure I have enough data to be firm about this, but I worry about potential side effects, but also for quality of life, that's also important too as well. So estrogens are for quality of life. Estrogens are also good for bone health, but there's better things for bone health. Exercise is better, and a little bit of calcium and keeping your weight down. So thank you for sharing that, Dong. I think so, but I know a lot of people, other people feel much stronger about this. In God we trust. Everything else needs data, and we just don't have enough data yet to be firm about this.
Mm-hmm. Yes, so we don't really know what testosterone does to normal aging men, but we do know that in men who have low levels of testosterone, so in hypogonadal men, testosterone therapy does lead to improved sexual function, improved muscle strength, improved fat-free mass, and improved bone density. So that is really the only population for which testosterone therapy is beneficial without any contention. But if a normal aging man were to take testosterone therapy, there would be risk factors such as worsening sleep apnea, acne or other skin reactions, stimulation of non-cancerous growth in the prostate, as well as growth of existing prostate cancer, the enlargement of breasts, as well as a decrease in sperm production, testicle shrinkage, and blood clot formation.
And you can see some people, is that for, sexual dysfunction, muscle mass fatigue, depression, lack of energy. You can see how testosterone can be quite appealing, and it may be actually very, and it is helpful in that circumstance, especially if you're deficient. And what the level should be as we get older is still in question. I know that there's total testosterone, free testosterone. It's like gives me a headache how to evaluate all this and learn about this. So we have lots to learn in this area, but you can see, look at the pluses and minuses, and we can certainly have a discussion with multiple physicians about this.
Mm-hmm. So, as Dr. Curnew mentioned previously, there are potential ways that you can help maintain your testosterone levels yourself. First, one of the methods is minimizing stress. So low testosterone levels have been linked with high stress levels. And so trying to minimize that stress is potentially a helpful way to help maintain testosterone levels. There have also been observed increases in testosterone immediately after exercise. Unfortunately, this increase doesn't seem to last for very long. However, we do know that exercise and a healthy diet can lead to weight loss, and obesity has been linked with low testosterone in men. So this weight loss can help improve testosterone levels for a lot of people. And with respect to diet, it's very interesting that people have found that there have been a few trials that have found that vitamin D supplementation has been linked to increased testosterone levels. However, we do know that vitamin D supplementation in people with normal vitamin D levels doesn't seem to show a considerable amount of healthy effects, but it's always a good idea to maintain good vitamin D levels.
The other thing that testosterone has been found to be potentially helpful in women who have lack of sexual drive. Testosterone can increase sexual drive.
Mm-hmm. So all of that being said, we can't really address the effects of hormone therapy without addressing one of the populations that very much use hormone therapy, and that is transgender individuals. So what are the effects, what are the cardiovascular effects of gender-affirming hormone therapy for this population? Before we get into that, let's take a look at what gender-affirming hormone therapy is. It's essentially when transgender men or women take hormones to develop the physical traits that best reflect their gender identity. For transgender men, that is men who identify as men but were assigned female at birth, they might take testosterone. And for transgender women, that is people who are assigned male at birth but identify as women, they might take androgen blockers or estrogen. And all of these can come in oral forms, they can come in injectable forms, or they can come in patches through the skin. So what are the heart effects of this hormone therapy in transgender individuals? So given all of the cardiovascular effects of hormones that we have previously discussed, you might think that there are increased cardiovascular risk factors. And indeed, it has been shown that in both transgender men and women taking gender-affirming hormone therapy, there has been shown to be an increase in serum triglycerides. So there's an increase in lipids in the blood. However, it's unclear what the long-term effects are. So we don't really know what its effects are on mortality, on heart attacks, on atherosclerosis. However, we do know that given these risks, transgender individuals should be assessed for cardiovascular risks before when they're considering hormone therapy. But in light of all this, it's also really important to remember that the goal of gender-affirming hormone therapy is to treat gender dysphoria. That is the feeling of incongruence between someone's identified gender as well as how their body presents. And this can lead to a lot of mental distress for a lot of people who are transgender. And it's been shown that gender-affirming hormone therapy can lead to improved self-confidence, decreased amount of mental distress and mental illness related to gender dysphoria. And so these substantial benefits has to be weighed against the potential cardiovascular risks of hormone therapy in this population. And the potential cardiovascular risks isn't really an excuse to deny transgender individuals gender-affirming hormone therapy. And so that basically concludes our webinar.
Back one slide again. Yeah,
Yeah.
that's very interesting. So transgender individuals are at higher risk for heart disease, that we know. And one of the things is that, what is the definition of male or female? It's not so simple. Is it a chromosome diagnosis? Is it a hormone effect? There's all sorts of permutations and combinations. So when I first started out my medical career, I thought it was black and white. It certainly is not. You can be partially male and partially female genetically and by different sex organs and by chromosomes and different hormone levels. So this is quite a complicated area. I don't claim to be an expert, but one of the things I will say to people that are transgender, you have to work hard at risk factor modification. Many people are transgender, struggle with their weights and risk factor controls. Make sure that that psychiatrically that they get the proper treatment that they may or may not need. But is that and we've made great advances in this area at this stage of time right now. So male, female, I'm not sure what the definition of a male or female, and which you feel is right for you. That's right for us too as healthcare providers. We want to help you in that area, but make sure you know your blood pressure, your cholesterol, your weight. When we start playing around with hormones, we can see that many times we can actually increase your cardiovascular risk and cancer risk and blood clot risk. So make sure you talk to people that are specialized in this area and really take care of yourself. So hormones do good things and bad things, and balance of this is quite crucial. Thank you for sharing that.
No problem. But yes, that concludes our webinar on the effects of taking external hormones and their associated cardiovascular risks.
That was just Wonderful. So I started off my medical career in working in a lipid clinic. I used oral estrogens. I used a lot of Premarin and progesterone agents to improve LDL cholesterol, boost HDL cholesterol, increase vasomotor tone, but I increased risk of thrombosis. I increased risk of triglycerides. And I learned along the way that I used the best evidence at that point in time. At one time, we thought very strongly that hormone replacement therapy was cardiovascular protective. We found out it wasn't. And how that's going to evolve at this point in time, we still have a lot to learn at this point in time. But certainly, taking appropriate hormones does increase your body response, and it can increase bone mass. It can help mood. Um, but it can also increase risk of cardiovascular disease and cancer as well. So speak to lots of different people. Your family doctor will give a perspective. I'll give you one perspective, another a urologist or so-called hormone specialist will give you another interpretation as well. So it's a conversation that you'll have with multiple individuals in this. And I want to thank Dong and her team for putting all this together in so many ways. And that was just wonderful. Thank you. Are there any questions from anybody? Stuart, what's your thoughts?
Well, it's a very interesting topic for me today, and I have a few thoughts. And I was keeping some notes down because it is such a topic that I don't know a lot about, and I wanted to learn more about today. The first conversation, which was about menopause, I was really interested to find out that estrogen and progesterone previously was prescribed in managing or used in care, especially in cardiology care. And managing cholesterol levels and things of that nature. But the conversation about increased risk of strokes, increased risk of cardiovascular disease and breast cancer was certainly enlightening. And to me, as you said, the choice to take these sorts of hormones is largely dependent on quality of life and managing menopause and menopausal symptoms. As you said, Dr. Curnew, if you are to use those sorts of things, it's oftentimes best to use it acutely, lowest dose possible. But as you mentioned, that is a decision to be made between the patient, the cardiologist, or the healthcare provider to come up with something that's going to be balancing the quality of life of the patient with also some of the potential side effects or concerns that come with using those sorts of hormones. The topic that is relevant more to me with the testosterone is very interesting. As I've discovered today in the conversation, my testosterone is going to continue to be peaking, but in about 10 years, it's going to slowly start to go down. And I was really interested to hear about what the research is available. So I appreciate Dong for showing us all the research available. For me, my takeaway was that there maybe isn't just a lot of research available that is clearly indicating whether it's beneficial to go on that as my testosterone begins to go down as I grow older. And just to hear about some of the ways that I can naturally approach this challenge in keeping my testosterone levels where I'd like them to be with exercise, sleep, activity was really interesting. So as I grow older, I'm going to continue to try my best, and it's not always easy, to balance stress, to balance activity, to eat healthy foods as much as I can, plant-based dieting when I can, get the isoflavones as Dong was talking about today to get my vitamins and also my calcium. So that's sort of my takeaway that was relevant to me. I learned a lot today. The one question I have, or the thing I was interested in that really made me sort of, think, was the timing hypothesis study, where they said that for the period after menopause up to 10 years, it seems like potentially taking hormone replacement therapy doesn't have the same cardiovascular risks as it does later in a person's life, multiple years after menopause. And for Dong, for Dr. Curnew, I'm going to look into this myself, but was there any sort of explanation from the researchers in the paper as to potentially why this might be, or is that something that they're still trying to figure out? Because that was really interesting to me, and I didn't expect that just based on what we were talking about before this study was mentioned.
Do you want to go first, Dong? I have some ideas.
I think you can go for it.
Okay. So first of all, is the risk of heart disease goes up after the menopause, very, very high for women. So women in their early 50s, the risk of heart disease overall is not that particular high. It goes up well after the menopause. So heart disease becomes more and more important later in life. Women develop on tradition heart attacks 10 years later. So the hormone change will cause that potential problem later on. Number one. Number two, if you analyze data, the trials are calculated to give one p-value and to give it answers a question. And the question is, does hormone replacement therapy, are they protective or harmful? And the two biggest trials show that they were harmful. So if a trial is harmful, it's a negative trial. And then to start data dredging is fraught with problems. And so this is, and there is a smaller trial of about 1,000 women saying that it was okay. That trial is way underpowered to answer that question with different estrogens and progesterone preparations. So we also know that during the time of menopause, estrogens are vasodilators in tissue models. And maybe after menopause, you lose that because the flushing part goes away later on in that. And so that's a vasoactive process. So the vasodilatation, the health industry, maybe that's true. The thrombogenic risk is seen all through the phase. It's seen with the birth control pill. We mentioned that women who smoke, overweight, have more problems with clotting disorders, and estrogens and progesterone, especially estrogens, contribute to that effect. So I think I can give you all sorts of reasons, but the number one reason is that from a pure trial perspective, the trials show that hormone replacement therapy are harmful. Someone has to do a big trial of 10,000, 20,000 women at around the age of 50 or so, and giving hormones at that point in time is truly safe. We don't have enough data. We have subgroup analysis and we have small data sets. And again, most women don't get heart disease in their 50s. It's usually later on after that. So we'll miss that. So that's my take on that. Dawn, what's your thoughts?
I honestly don't have much to add. I think, as Dr. Curnew mentioned, we don't know for sure that this is, I guess, that for these populations, hormone replacement is indeed safe, especially given the initial results of the WHI. But it is very interesting potential mechanisms that they might have proposed, but I didn't look into that. And yeah, I think that's definitely something that something that I will look into as well.
Yeah, I've been thinking about this for quite a bit because I probably early in my career caused heart attacks by giving hormones based on the best data that we have, and we change. And I feel bad for that aspect of things, but I also feel good as using the best science at the time. And I can use the best science as we develop at this point in time. I really like your slide about if you're going to take hormones, make sure that you control your other risk factors. Make sure you have a good blood pressure. You're working out your weight and lifestyle changes. Get your cholesterol to a really low value. So if your cholesterol is very low, the effect of hormones will be very, very small on the risk of heart disease. And if you take it for the shortest period of time, your quality of life will be better, and your risk of heart disease and stroke and blood clots and cancers will probably be low as well. So that's and you can also use topical estrogens too as well for vaginal dryness and thin condition. They don't get absorbed very much to the body, and we think that maybe patch form of estrogens may be safer and less thrombogenic. So there's different cocktails available to make that work, and we can find a way to make people comfortable through menopause. About testosterone, I think we just there's pluses and minuses, and so quality of life is very important. So if you find that hormone replacement increases your quality of life and it might increase your risk of having a cardiovascular event, that's great. At least you know the pluses and the minuses. So quality of life is still very, very important as well. I don't know, today I got to go and exercise for about four hours today, and my body's sore, but my quality of life is better. I'm going to sleep well tonight. Well, listen, I want to thank everybody for putting this together. This is a tough presentation to put together. Dong and your team, you did a fantastic job. You highlighted so many important things, and thank you so much. And I hope people take a look at that. And I want to bid everybody just a happy holiday. And I think next week we're taking a week off. Is that right? It's exam week?
Yeah, we'll be taking 1 week off. So enjoy the 1 week, and we'll see you the following week for a new webinar, 7 o'clock on Friday.
Well, listen, I want to thank everybody and happy holidays, and keep exercising, keep watching your diet, and control your risk factors. Good night, everybody.
Good night, everyone. Take care.